Good evening, one and all. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you for the 37th episode of Optometry series. I'm very happy to welcome my team members, Ms. Anshika ma'am and Ms. Meenakshi. Hi, both of you. So, Anshi ma'am, so what is today's topic and who is the moderator, ma'am? So, please introduce our moderator as well.
Thank you, Gomati. So today's topic is a very simple but a very, very important topic in any type of eye care, whether it is ophthalmology or optometry. So the topic is basics of refraction, and today's moderator is Renjini ma'am, who's been one of my teacher also. So why Renjini ma'am? Because she is the most patient faculty you can ever get. She can teach you, and she with such love she teaches that you will always remember and cherish that. So I'll have a proper introduction from our MC today. So over to you, MC.
Yes, the MC for today is Ms. Belicia. Yes, Belicia.
Good evening, everyone. I am Belisha, studying second year Bachelor's in Optometry at Dr. Agarwal's Institute of Optometry. It is my distinct pleasure to welcome you all for the 37th episode of Optometry series. Today, I have the privilege of welcoming an esteemed guest who has made significant contribution to the field of optometry. Please join me in welcoming Ms. Renjini Madhavan. Ms. Renjini ma'am began her illustrious journey in optometry with a Bachelor of Science degree from the Elite School of Optometry in 1999. Following her graduation, she joined Shankar Nethralaya as an optometrist and later served as faculty at the Elite School of Optometry, Chennai. Throughout her career, ma'am has held several key positions, including holding the refraction clinic, binocular vision clinic, computer vision syndrome clinic, direct vision screening, and Navasuja Shankara Nethralaya optometry. Currently, ma'am serves as the manager of training in optometry. She plays a pivotal role in shaping the next generation of eye care professionals. Ma'am is a dedicated trainer for various optometry and ophthalmology programs, including fellowship, diploma, and research course. She has converted over 500 CME sessions, training numerous professional and ensuring the highest standard of eye care. In addition to her training responsibilities, she has been instrumental in developing the Titan Eye Plus optometry training module and collaborating with the e-learning team to create a robust learning management department. Ma'am's contribution to occupational optometry are noteworthy. She has spearheaded the development of the computer vision syndrome clinic and has tirelessly promoted awareness of CVS and direct vision screening through various initiatives in schools, colleges, government, and organizations, bank and IT industries since 2003. Her work extends to the industrial sector, where she has conducted vision screening for the companies like Shell and Murugappa Group. She has also organized and participated in numerous community vision screening programs related to digital eye strain and computer vision syndrome. As a respected and renowned speaker, ma'am has represented Shankar Nethralaya at various nation and international platforms, sharing her expertise on eye care, digital eye strain, and optometry management over the past 20 years. Ma'am's contribution to academic include co-authoring textbook on occupational optometry, being a part of 5 research groups, and coordinating multiple international and national conferences in optometry. She also co-guide master's research work for the Dr. MGR University in Chennai and currently pursuing her PhD in digital eye strain and Sastra University, Tanjavur. Thank you, ma'am, for being with us today. We are eagerly heard from you and learn from your vast experience and insights. The presenter of today is Miss Afrin Farhana, a technical team member of Optometry series and studying third year bachelor in optometry at Dr. Agarwal's Institute of Optometry. Ms. Farhana, please start your presentation.
Thank you, Bilicia. So today's topic is basic of refraction, and the introduction is refractive errors are the most important common cause of visual disturbance worldwide. Symptoms related to the refractive errors are quite disturbing and may even disrupt the normal lifestyle of individuals. As per World Health Organization, myopia is projected to increase from 22% in 2000 to 52% of world population by 2050. Both genetic and environmental factors contributes to the increases in myopia. Retinoscopy is a technique that utilizes an external source supplied by the retinoscope to project light rays through the transparent ocular media to observe the reflection of the retina. It is objective and accurate, and it is used to evaluate the optical state of eye. Retinoscopy procedures can be broadly categorized as static or dynamic. Static retinoscopy requires the patient to be in the relaxed accommodative state, while the dynamic retinoscopy requires active accommodation. So retinoscopy can be done with and without cycloplegic agents. So these are the types of retinoscopy, static and dynamic. In dynamic, we have sometimes types of retinoscopy: Bell, Knot, Mohindra, and Radical. And now we come to the static retinoscopy. During the static retinoscopy, examiner observes for the reflex neutralization. During this consistent patient fixation at immovable visual stimulus, target or optotype situated at the optical infinity defined as 6 meter or 20 feet. So static retinoscopy, non-cycloplegic or cycloplegic objective refraction assessment. Non-cycloplegic objective refraction is carried out while the accommodative facility remains naturally intact. In this, it is also termed as a dry retinoscopy. In cycloplegic retinoscopy, the accommodation naturally arrested temporarily, and it is called as a wet retinoscopy. And these are the reflexes, the neutral point and ametropic reflex. And the inferences of reflex, properties of reflex, movement with means we need more plus for neutralization, and against we need more minus for neutralization. We should check for the brightness. For dim brightness, we are far from the neutralization, and if it is bright, it is close to the neutralization. And width, narrow, far from the neutralization, and wide, close to the neutralization. If this, we also note speed, slow speed, far from the neutralization, and the fast speed, close to the neutralization. Characteristics of reflex: no movement, neutralization. If it's slow, dull, narrow, it has a lot of width. That means we need more plus for neutralization. If it's fast, bright, and wide with movement, we are near to a neutralization. We need low minus for the neutralization. If it is fast, bright, wide, confusing, we need less minus for the neutralization. If it is low, dull, and narrow, we need more minus for the neutralization. For finding cylinder, in case the axis is not 90 and 180, finding a cylinder power might be difficult. Hence, squeezing or swirling is used. Skew, align axis toward the oblique motion of streak. Straddling, to rotate 45 degree. And this is streak of skew. Then the procedure of retinoscopy should be dark room illumination, and the examiner and patient should be seated at an eye level. Then ask the patient to fix it at the target of 6 by 60. If patient right eye is examined, examiner's right eye with the retinoscopy in right hand, and the working distance lens should be in arm length. Examiner's both eyes should be open. Fog the eye. Check target is visible. Examiners observe a red reflex in the pupillary area. Retinoscope is moved in both horizontal or vertical meridians and neutralized. So working distance calculation, it is calculated by the measuring arm length. Example, if it is 66 centimeter, arm length has a working distance of 100 by 66 plus 1.5 diopters. It is not only compensate for the distance of examiner, it neutralizes the effect of accommodation to an extent. So indications: refractive error, amblyopia, red reflex to identify leukocoria, can be used to assess Bruckner's test. Clinical significance of refraction, anomalies of the optical state of eye. That means refractive errors can be identified. Complaints like child unable to see black background at school, or the presbyopic patient finding it difficult to read small prints or blur vision even after correction can be addressed. It is also a great significant when visual failure is not due to refractive error. The interaction between the optical anomalies and an ocular disease have both diagnostic and therapeutic implications, like a cataract patient may have a visual acuity of 6 by 12, then corrected up to 6 by 6 with glasses is not needed for cataract surgery. Also, after operation of cataract extraction, post-operative, the patient also is needed for refraction. Then we come to cycloplegic refraction. Cycloplegic drugs are often used to evaluate patients for underlying refractive errors. Cycloplegic cause temporary paralysis of the ciliary muscles, allowing the determination of total refractive errors. So additional indications for non-verbal and non-communicative children, patient with a high heterophoria, accommodative esotropia, accommodative asthenopia, poor reliability between dry retinoscopy and with subjective findings. The indications are pseudomyopia, young patients who have symptoms but no significant refractive error, inconsistent endpoint of refraction, in children, strabismus, and latent hyperopia. So choice of cycloplegics. For atropine, we used for the age of people who are in 0 to 7 years, and the concentration is 1%, 1 drop twice a day and 3 days. And peak effect of the cycloplegics is 3 days, and the duration is 10 to 14 days, PMT 14 days. Tonus allowance, our residual accommodation is of plus 1.5 diopters, and cyclopentolate we used for the years between 7 to 15 years, and the 7 to 12 years to be in 1%, and 12 to 15 years is equal to 0.5%, and 1 drop 15 to 20 minutes. Cycloplegics is of few minutes, maximize in 30 to 60 minutes, and duration is of 24 to 48 hours, and the total allowance is of plus 0.75 diopters to 0.5 diopters. Home atropine we used for age for people 1 to 15 years, 1%, 2% is a common, 1 drop repeated twice after 10 minutes. And its peak effects is about 45 to 9 minutes, and duration 24 to 48 hours, and the total allowance plus 0.75 diopters. And the tropicomate we use for all the patients, maximum 2 drops after 10 minutes, 4 drops total, and its peak effects is about 30 minutes, and the duration 6 to 8 hours. Total allowance less than 0.5 diopters. Extra challenges in retinoscopy. Retinoscopy may be difficult to perform accurately in the conditions like nystagmus, strabismus, aphakia, corneal opacities, pupillary miosis, cataract, opacities in media, faint retinoscopic reflex. In case of nystagmus, retinoscopy should be performed in the null zone if such present. In case of strabismus, The patient is asked to alter gaze to another fixation or close that eye so that the test eye is better positioned, and should perform retinoscopy slightly off axis. In case of aphakia, the retinoscopy should be performed after dilation. So we now come to the retinoscopy. The retinoscopy objectively determines the point that is conjugate to the retina. When the patient is viewing a particular near target, the accommodation is active. No working distance power is added or subtracted from the findings. Goal is to determine accommodative response. Also helps to determine the most appropriate near prescription with testing conditions. Frequently used procedure in clinical practice. Monocular estimation method, not retinoscopy and Bell's retinoscopy. This is a monocular estimation method. Not. It determines a lag or lead of accommodation by moving retinoscopic aperture towards or away from the eye. Target is letters around the aperture of near point card. At a distance of 40 cm, the accommodative response in diopters is subtracted from the accommodative demand to determine the accommodative lag or lead. This is the picture of not retinoscopy. And the radical retinoscopy we done for the patients who have small pupils, cataract, media opacity, and faint retinoscopic reflex. Instead of performing at usually working distance 50 cm, the examiner move closer to the patient so that the observable reflexes can be obtained. May involve working distance as close as 20 cm or 10 cm. Finally, the dioptric of the working distance is deducted from the retinoscopic value. Bell's retinoscopy, the retinoscopy remains in fixed position and the target only is moved. The retinoscopy is formed from the fixed distance of 50 cm. The distance between the retinoscope and the target when change in motion occurs is a physical measure of lead or lag of accommodation. Subjective assessment. After all the objective refraction is done, we just come to subjective refraction. Subjective refraction, assessment of refractive status by combination of spherical and cylindrical lenses to determine the best corrected visual acuity with accommodation relaxed. Steps involved in subjective refraction is defogging, duochrome, JCC, and binocular balancing. Duochrome or bichrome test. Usually, binocular balancing procedures are done when visual acuity is similar or near to similar in both the eyes. Starts with the best vision in both the eyes. Duochrome, red and green bar, the patient is asked to report letters from which background appears clear monocularly. It works on the principle of chromatic aberrations. If both the bars are clear, they are corrected equally without any overcorrection or undercorrection. If red appears clearer than green, it can be due to uncorrected myopia or overcorrected hyperope, should add minus 0.25. If the green is better, it is due to under-corrected hyperope or over-corrected myope, should add plus 0.ds to make equally clear. Next comes JCC, to refining axis. Put the cylindrical lens discovered during retinoscopy in the trial frame, occlude one eye and ask to focus on the line that is clearest with the other eye. Hold the JCC with a handle parallel to the axis of cylindrical lens in the frame. The axis of the JCC, white and red markings will be at 45 degrees to the axis of cylinder in trial frame. Flip the JCC so that the position of the red and white marking is reversed. Ask the patient to tell about any changes in visual acuity. If the patient notices no difference between the two positions, then the axis correcting cylinder in the trial frame is correct. If visual improvement is attained in one of the position, minus correcting the cylinder should be rotated in the direction of minus cylinder component. Red of the cross cylinder and plus cylinder should be rotated in the direction of plus cylinder component, white of the cross cylinder. Repeat the test till neutral point is reached. To refining the power in JCC, put the cylindrical lenses in the trial frame, occlude the one eye and ask the patient which line is the clearest. JCC is placed with its axis parallel to the axis of cylinder in the trial frame. The axis of JCC white and red markings. Flip the JCC and ask the patient to tell about any changes in the visual acuity. If the patient notice no differences between the two positions, the power of the correcting cylinder in the trial frame is correct. If visual improvement is attained in one of the position, a corresponding correction should be made, verified till final correction is attained. Now we are going to refine the power. Then the last step of the refraction is about binocular balancing. It is the final step of subjective refraction. And this balancing technique is not to balance the visual acuity, but balance the state of accommodation of two eyes. This allows both eyes to have a retinal image simultaneously in focus. This is done with the assumption that each eye has been fully corrected. During monocular refraction, the practitioner considered only one eye at a time. But we normally use both eyes so that the clear and the comfortable binocular single vision is the ultimate goal. So techniques of the binocular vision. Visual acuity of both eyes is a key point in selecting the technique. So the types of fogging and the alternate occlusion method, diochrome, prism dissociation method, the while infinity balance technique, and the polarized filters. Fogging and the alternate occlusion method, and it's an aim to achieve the binocular vision. It avoids the rule of maximum plus for maximum visual acuity and minimum minus for maximum visual acuity. And it requires occluder, and the initial target to be given for the patient is 618, and fog with +1 diopters in the both eyes. Compare OD and OS. Ask the patient which is clear by alternately occluded. If the both eyes are balanced, the patient will report equally blur in both the eyes. If the eyes are not balanced, add +0.25 to the better eye until the balance is achieved. The ultimate goal is to create equal blur in both the eyes, indicated equal balance between eyes. Now slowly defog both the eyes simultaneously until the patient reads 6/6. And the prism dissociation method, with best corrected lenses in the trial frame. Initial target to be given is 6/18 and fog with +1 diopters in both the eyes, and also with 3 or 4 prisms base up and base down. Compare OD and OS. The image from both the eyes gets displayed. When the both are blur, it is balanced. But with one eye sees clear image, add +0.25 to the better eye. Both the images are distinct and blurred. Having achieved the balance, prism is removed and defogging should be done to get maximum vision with the highest plus or minimum minus. Tawil infinity balance technique. A set of letters are shown and they're divided with the septum in the middle, which marks some letter for each eye. If all letters are seen equally and clearly, implies binocular balance. Polarized filters. They are used to partially dissociate image. While placing polarized filters, each eye sees a separate image. If all the letters are seen and read clearly, endpoint is achieved. Not preferred, strabismus patient, suppression, one-eyed, imbalanced correction often leads to asthenopia due to unstable accommodation. So errors in refraction. Refraction, the process of determining patient refractive error and prescribing corrective lenses, can be subject to complications. Errors. Inaccurate autorefraction. Autorefractors may not always provide accurate measurements, especially in patients with irregular astigmatism. Incorrect subjective refraction. The patient responses during the subjective refraction process may not reflect their true refractive error. And inadequate cycloplegia. Insufficient cycloplegia can lead to inaccurate measurements in child accommodative spasm. Instrument calibration errors and properly can lead to calibrate instruments inaccurate measurements. Observer bias. The examiner bias can refract refraction outcome. One of the case example, a 25-year-old male came with a complaint of reading difficulties, blur vision, and headaches. He could not recall exactly when the symptoms started, but emphasized that they have become worse over the past few weeks. Occasionally, he experiences double vision. He had no remarkable ocular and medical history. On examination, the distance visual acuity was measured using a Snellen chart at 6 meters, and the near visual acuity was measured using a continued text chart at 40 centimeter. Distance 6'9", with the improvement of pinhole, he read 6/6, and near he read N6. So objective refraction in retinoscopy plus 1.25 diopters and minus 0.25 DC into 180 clear glow is shown, plus 1.25 DS minus 0.25 DC 180 clear glow, full neutral glow is seen. Subjective refraction, right eye plus 1.25 DS, he reads 6/6 and N6. Left eye plus 1.25 DS, 6/6 and N6 he read. IPD 71/67 mm. And NPC 26 centimeter, and push-up to blur method 3 diopters, distance foria ortho, near foria 3 ET, AC by A ratio calculated 4.8:1, and base out near 70:20:10, and base in near 13:21:13. Vergence facility is of 12 CPF, and negative relative accommodation is of 2.5, and positive relative accommodation minus 1.25, and BAF 5 CPM, difficulty clearing in negative lenses, and MAF 4 and 5 CPM. In slit lamp, the right eye structures, eyelid and eyelashes, no dandruff, clear with lashes alignment. In left eye, no dandruff, clear with lashes well aligned. In conjunctiva, clear, no injection, no growth, slight pigmentation. In left eye, clear, no injection, no growth, slight pigmentation. Clear, no stains with fluorescein cornea. Clear, no stains with fluorescein. Anterior chamber in right, deep and quiet. Left eye, deep and quiet. Iris, brown, flat and uniformly pigmented. In left eye, brown, flat and uniformly pigmented. Pupil, round, equal, reactive to light, and no RAPD present. And left eye, no round and equal, reactive light, no RAPD. And lens, clear, no opacity. In left eye also clear and no opacity. Vitreous, clear, no cells. In left eye, clear, no cells. Fundus remains within normal limits. Diagnosis, hyperopia, and it is accommodative insufficiency. Advice, optical corrections with a vision therapy was prescribed. Pencil push-ups, 3 separate 20-minute sessions in a day for 2 weeks. And these are my references. Thank you.
Thank you so much, Afrin. Very detailed and elaborate presentation. And ma'am, I request our moderator now to share your inputs, ma'am.
First, thank you, Afrin, for that presentation. That was very nicely presented. We'll have a few points to discuss, but before that, I'd like to thank the institution, the Agarwal Institute of Optometry, for calling me over for the session. Thanks, Anshika, for choosing my favorite topic, refraction, for me. And Jershiya, thank you for introducing me. So we'll go over to the topic. Can we have the slides? It would be nice if we can just review them. Okay, so yeah, you take your time. And while we are getting the slides up, generally, I mean, if you all have your mobiles active and if you can chat, I would love to see your responses for what I'm asking you. And I'll have to see where I can see the responses. I'm not too familiar with the Zoom mode of classes. We generally don't use the Zoom mode. We go for the classroom mode. So,
Ma'am, if there are any answers in the YouTube, Meenakshi will be able to see it and she'll tell you.
Yeah,
And
so
if there are any
this chat
answers,
I can see it.
Zoom you won't be able to see, ma'am. All the
Okay.
students are connected through the YouTube. So
All
they
right.
so they might give you the answers in YouTube.
Sure. So there's somebody to lead us to their answers, right?
Yes,
So,
Meenakshi is the needful.
sure. Thank you, Meenakshi. So my first point to all of us is, we've seen what the slides told us. We started off with what is a refractive error, what kind of refractive errors we're actually going to find. And we also saw that we started off with retinoscopy. But can you tell me what is the first step of refraction as such?
Students, you can type your answers in chat box.
If it's like very difficult for us to get the answers on, I can just go on, give a half a minute for people to try to respond, because is there a time limit? Because we're 15 minutes away from 4 o'clock.
That will be fine, ma'am. If we get any answers, I'll let you know. Yeah.
Right. So, okay. So my factor is always your vision assessment is the first part of your refraction. And vision by itself starts when you're calling in your patient, where you have to observe how they walk in, how they respond to a call. Those are the first places where you're going to start your refraction. So visual assessment is very, very important, because if you do not know what the vision of the patient is, you're not getting a lead as to what your refraction is going to be at all. So the next common question which I ask people is, if you have a patient who's reading a particular line on your Snellen chart, you've mentioned in the case that you first check visual acuity. So if your patient is reading a particular line, we're taking just the Snellen, okay? Is there anything which you can predict from the vision of the patient as to what is the power they can have? Because that's going to decide how well you do your subjective refraction. So is there anything which will decide what is the power you can predict based on the vision with your Snellen chart? Okay, so I'll basically tell you what we generally explain. It is that each line of your Snellen acuity is equivalent. 0.5 diopter per line is kind of, yes, Harshini. So when we say 0.5 diopter, it is like ideally for each line it is 0.25 diopters or 0.5 diopter of cylinder. You can give a 0.25 more in certain conditions, but otherwise it's 0.25 diopters, and it works best with myopia and minus cylinders. When it is a combination of hyperopia and cylinder, there's a lot you'll have to think before you decide, because your spherical equivalent literally makes it zero when your errors are of a different kind, where suppose you have a +1 with a -2 cylinder, cancels to zero, but will the patient have a difficulty in vision is a question which comes in there. Okay, so we actually talked about visual acuity. So it's very, very important that you'll have to know the visual status of the patient. Again, why we emphasize this is, many a times what we find is, we have patients coming in with low minus refractive errors. But when we do our retinoscopy, we find that their retinoscopy is more towards the plus direction, or it is even less minus than what they are wearing. So in that case, unaided visual acuity is something very, very important to make sure we're not overcorrecting the patient. This is something which is very commonly happening. So that's why I wanted to emphasize that first place. Okay, and another thing which I wanted to mention is, besides the retinoscopy and the acceptance procedure, which you have mentioned here, it's very important for us to be sure about how we do the lensometry, use the values of your keratometry, whatever means you're using to get your corneal curvature, and also the basic orthoptic methods, that is your cover test itself, to decide if your refraction is right or wrong. So again, history is very, very important, because if you don't know what is the occupation of your patient, you don't know what you're prescribing them for. So it's very important to know what they're doing, what kind of task they're actually covering. And it's important, we haven't covered near correction here, so I'm not actually going to be saying much about it. But please remember, when you're correcting them, make sure you know what their requirement is. So, right, we've gone through the introduction for retinoscopy. Lovely. We can move on to the next slide. Move on, please. Yes, now here, okay, I believe you have skew and straddle a little later. Yeah, please move on. Move on to the next slide. Yeah. These methods, I'm sure you've learned it quite a lot, so you needn't even go through it. Okay, you know what is the static retinoscopy and the dynamic retinoscopy, cycloplegic and non-cycloplegic. Very beautifully in the next slides, she's also mentioned, yeah, this is something which will help you quickly determine what your power is, because when you're looking at your reflex, we all know that the hyperopic reflex is going to look a little brighter than the myopic reflex, yes. But when you're looking at your reflex as such, is it broad, bright, fast? It means you're near neutralization. Don't waste time in your retinoscopy looking for small changes when your reflex is going to be narrow and slow. So make larger chunks of changes so that you won't spend a lot of time during your refraction, during your retinoscopy itself. So this is going to be your lead for it. Right, please move on to the next slide. Please move. Yeah, now this is one thing which we always want you to follow, which is finding the right axis for your cylinder. Now, like she had already mentioned, you're going to scope all the axes, and you're going to find that if it is a sphere, it's going to be neutralized throughout 360 degrees. But if there's one area which does not neutralize, that means that is where there is more power, and you put your cylinder axis over there. Now, like you see in this drawing, you see that the streak is in one place and the reflex is in another. So in the next slide, I believe she's, can we go to the next slide? Yeah. So now you have skew being explained over here, wherein you're going to turn the axis to go towards the direction of where your the internal reflex is, so that both this reflex and your intercept are aligned. Okay. And you go ahead and neutralize. So what is straddling? Straddling is basically when you've decided this is your axis, you want to know if you've got the right spot. So you go 45 degrees. 45 as such means you should go equally on either side. When you go equally on either side, you've got to make sure that the thickness of the reflex is the same on both the positions. When I go 45 degrees to the right, it should be one thickness. And when I go 45 degrees to the left also, it should be the same thickness. If it is not, it means that you are not at the correct axis. There is more power in one zone. So which reflex will be the one with more power, the thinner one or the thicker one? From the previous slide, which spoke about the quality of the reflex, we know that the thinner, slower one is the one which has more power, which means there is more refractive power there. So that's going to be the place where the axis is going to be. So turn towards the thinner reflex. All right. So can we go to the next slide? Right, no, previous one. So, okay, now you've mentioned over here, when you refract the right eye, you're going to use the right eye to examine, and for the left eye, you're going to use the left eye to examine the patient's retinoscopy. Working distance is arm's length. Now, I know after these slides, she's explained what is the working distance and how you calculate it. Now, I'm sure those who have the Zoom do have the raising hand option, or you can even just ping yes if you have the method of doing it near you. How many of you have really measured the distance of the patient's, or let's say the trial frame and your retinoscope when you are in the process of working? Have you had that done? How many of you have actually measured the distance between, okay, Swetha, yes. So how many of you have actually measured that distance? And how many of you have found it to be 66 or 67? Yes, Padma Shri, yes. Okay, if I believe you minus 67. Wonderful, Harshini. So, okay, somebody has said mine is lesser than 67. So, you can see that if somebody is quite tall, they'll have a longer arm. So beyond 67, less than 67. I can tell you when I do my retinoscopy, if I'm going to hold the lens and I'm going to scope, it is 50 centimeters. So what should the working distance which I compensate for be? It should be 2 diopters, right? So similarly, my request to all of you would be to make sure that you measure the distance when you are working. Ask one of your friends to do it for you. You don't consciously do it because you wouldn't always follow that. So see what you always follow. It should never be less than 50 centimeters ideally. And make sure you make for that compensation when you're doing your retinoscopy. So otherwise, all the points mentioned here are fine. Please go to the next slide. Okay, so this is what she's already said, the methods of doing it. Indications and refractive error, red reflex to identify leukocoria and to assess brightness test. Okay, there are a lot more, so you know where you'll use it. The next slide, please. Okay, please move on. Okay, now here you have, this was something when we started itself, I thought, please move over to the next slide. So depending on the, go on please, yeah, this one. So depending on the drug which is being used, you can actually tell the patient if the effect of your cycloplegia would go off sooner. So you know atropine is going to take around 14 days for it to go. I mean, you'll have to have your PMT done after 14 days. After 3 days, you've got to have your retinoscopy done to find out what is the effect. And atropine is so good that there's hardly any residual accommodation left. And the other 2 drops, which you can see, cyclopentolate and homatropin, you have to note when the drops have been last put, and you'll have to make sure it is done on time. The compensation for the tonus is one factor which you would generally have to remember. And when it's like, generally people don't consider tropicamide to be a good cycloplegic, but then when done on time and for people who can't hold on and wait to come back, at least some effect is there. So within half an hour, if you do your refraction with the tropicamide, though you can see that the residual is 1.5, you can be the judge to whether the patient is really accommodating in your dry refraction itself to make a decision just based on the tropicamide. Next slide, please. Okay. I was seriously wondering why you thought aphakia was a challenge in retinoscopy. Is it because it's a high power? Afrin? Now, this is something which I wanted to ask. Some questions were for Afrin. What was the reason for considering aphakia as a challenge in retinoscopy? Is it because it's a high power?
Yes, ma'am.
So, which means when you start off retinoscopy and if you don't know if it is aphakia, you see a dull reflex. Is that what you're trying to imply, Afrin?
Yes, ma'am.
Okay, so in that case, whenever you're seeing a dull reflex, what would you advise us to do?
I add plus minuses, ma'am.
Yeah, so you can add higher plus or higher minus and check if there is a change in the quality of the reflex. If you're seeing a dull reflex, add a higher plus or a higher minus and see if there is a change in the quality of the reflex. What's one other method with retinoscopy which you can do to verify that? You can go sleeve up. We work with the plane mirror, right? So suppose you have a retinoscope which has both plane and the concave mirror. When you go sleeve up or sleeve down, depending on the device you're using, use the concave mirror and your reflex actually becomes brighter and sharper. So what is not seen with the plane mirror will be seen in the concave mirror, which helps you determine that, okay, there is an error and it is not just the media which is hazy, right? So then you will make an attempt to refract it still further. And for strabismus, you find that it is a challenge basically because any reason you want to give, Afrin? Why is it difficult for strabismus? You've given explanations later, but why do you think, as a person who's doing retinoscopy?
The problem is fixation, ma'am.
Right. So what is happening with fixation is one eye might be turning off. And why is fixation important for us?
For visual chart, ma'am. For seeing visual charts.
Okay, now the patient has to be giving a fixation is what you're telling me, right? So
Yes,
the
ma'am.
patient has to give a fixation at a distance target, which is again going to help them relax their accommodation. Moreover, you have to be refracting at the fovea or at the macula. So
Yes, ma'am.
for that, you have to be online with the patient, isn't it? So
Yes,
that's
ma'am.
another reason why you're saying it's difficult for strabismus to get your patient to look straight. And you very rightly said before, later on that you have to block the other eye to get the eye to come straight. Corneal opacities, believe me, yes, it is always a dicey thing to find out the right axis. And I know you're all equipped to find out all that. Myotic pupils are difficult things, and opacities and faint retinoscopic reflexes, definitely fine. Please go ahead.
Yes, ma'am.
Okay. No, yeah. In cases of nystagmus, the previous one, please. Yeah. In the cases of nystagmus, generally, if you ask the patient to go to the null zone is usually where? In convergence. So in convergence, usually it will be difficult for you to do your retinoscopy. So when you don't occlude the eye itself, you're not going to make it any worse. So good enough. When you have squint and nystagmus, that becomes difficult. I accept that. You have in the third bullet point mentioned you should perform retinoscopy slightly off axis in the strabismus case. Can you clear your point over there as to what you're trying to say by that? You said you should perform retinoscopy slightly off axis in the case, I assume it is in the case of strabismus, right?
Ma'am.
Okay, so ideally that is because if you're going to be on axis, the other eye is occluded, so they don't have anything to fixate on, and you are straight in front of the patient is going to be looking straight at your light, which means they're going to accommodate. So to avoid that, you go slightly off axis, not very off axis, so that the patient doesn't actually look into the light of your retinoscope, right?
Yes, ma'am.
Okay. This is a question which I had for you, quite my doubt also. Why is it that we have to do a dilated refraction for aphakia? Is there any reason for it? Because we generally perform it even without dilation. But any reason which has been specified? Maybe we could get a different viewpoint also. Because ideally, aphakia, if it is going to be the central part of the pupil which is going to be refracted, it is easier for us to determine the error and not be misled by the periphery, because the patient is going to look through the central portion only. So why dilated refraction? Anything which you want to give us as extra information would
For
be good.
deep illumination, ma'am.
Sorry?
For dim illumination, ma'am.
Because it is going to be dim, you prefer to dilate the patient to get a brighter reflex, is it?
Yes, ma'am.
Okay, so ideally it is to give you a better view of the media.
Yes, ma'am.
But again, my point over here will be, if you're doing the refraction for an aphakic in a dilated state, please remember, don't refract the periphery, refract the central portion. That's very, very important.
Okay.
Except for in cases like where you're going to have marfans or subluxated lens, you in a dilated patient, you can do the periphery and phakic and the aphakic easily in that case.
Okay, ma'am.
Okay, lovely. Go to the next slide, please.
Okay.
Okay, these methods, you're going to talk about dynamic retinoscopy. One major point which I would want to say is, in any of these, your refraction, your retinoscopic procedure has to be very quick. The slower you are, the faster the patient's accommodation adapts, and you're not going to get the right value. So it's very important that you quickly refract. It should be in seconds, not even seconds, in a second. So that's one thing which I would like to add over here. Please go on, move over from dynamic. I think you've had enough of knowledge on the different procedures. So it's a cute kid over there. So if you'll go look into the different kinds of research done on the different methods, please move on. Okay, now we come to subjective assessment. Okay, so in subjective assessment, the steps involved, I see over here, you've mentioned defogging, duochrome, JCC, binocular balancing. Would you want to change that order for any reason?
No, ma'am.
Okay, ideally, you should do your JCC, finalize your sphere, and then do your duochrome. Because you are not going to get the same clarity with your duochrome if your cylinder has not been refined. So internationally, the process which is being followed is you defog. When you come to the point, excuse me for a minute, please. Yeah, I had some visitor in, so sorry for that interruption. Right. So what were we talking about? Yes. So JCC, the process which we follow is going to be, you have to start with fogging, stop at the point where any more sphere reduction is not improving the vision, and then you go ahead, do your JCC, and then do the duochrome and binocular balancing. This is the steps which you have to follow. So duochrome is supposed to be the end point of monocular subjective refraction. Okay. So it cannot, JCC should not be done after it. After you've done your duochrome, you check your final vision and move over to the other eye. Right. So that has been very clearly mentioned here. You check the sphere, you check your axis, and you recheck your sphere, you do your binocular, you do your duochrome, and then you shift over to the other eye. So please move on to the other slide. Oh, no wonders. We're already at 4. Okay, in JCC, there is just one point which I wanted to tell you, which is there is a mention made of, which side it has to be turned, white and red markings, what it represents. It's very important for you to find out what these white and red markings are, because in different places, you use different JCCs. If you'll go to the last slide, which shows the instrument as such, slide 35. Yeah. So over here, you have the metal ring JCC, which you are seeing, right? So over here, probably you have the red to be the minus and the black line as, or however, whatever you see that there to be your plus. In Shankar-Netralaya, what we use here is the typical plastic red and white dotted JCC. So in that JCC, the white dot represents minus and the red dot represents plus. So my question to you is, how will you identify what is the axis of your correcting JCC? I'd like you to go and try this. I want you to please pick up. I'm sure most of you know the answer to it, but I'm just mentioning it. Take a cylinder, take a regular trial lens, put it in front of a straight line and move it with the axis along with the straight line and see what the movement is. If you see a with movement, it is a minus cylinder. And if you see an against movement, it is a plus cylinder along that line. So we are looking at the axis, not the meridian, along that particular axis. So take that as your guide to determine what is the axis that you're actually handling. Red represents plus or minus in your JCC. Based on that, like she has beautifully put in a flowchart for us, you decide by asking the patient which of the two lenses are better. Like she said, you choose the right line, which the patient is able to read, and you show them just 2 choices. That is the most important instruction for your JCC. You tell the patient, I'll show you 2 lenses. Tell me which of the 2 is better. There's no 3, there is no 4. If there is no difference between the 2, it means changing the axis is not going to make a change. Correct? So that is the most important part of it. So when you're verifying your power also, lens 1, lens 2, which one is making a change? All right. So that is the most important point. And what is the end point of JCC, where they say both the sides are equal, or you're shuttling between 5 degrees this way and that way, or 0.25 this way or that way, and you stop. Many a times, if you're going to make more than a 0.5 change in the power, we skip adding the spherical equivalent to our sphere for that compensated power. When you do that, you actually have less work in your duochrome. So that's another point which would be very helpful for you. Please move on to the next slide. Okay, binocular balancing, very beautifully explained. Please go over to the next step. I have a question there still further. Okay, here. So whichever method you're using, prism, dissociation, alternate fogging, whichever it is, when you're going to put a 1 diopter fog, what is the significance of the 6/18 line being used is what I wanted to clear out over here. If you use a plus 0.75, it's a different line. We use 612. So this is basically like what I told you before. Each 0.25 which you add is going to blur the chart by one line. So 66, 69, 612, and 618 are 4 lines. So 0.25 diopter for each line. So if I'm going to blur 618, I put a plus 1 diopter fogging lens. So which means at that point, I expect both the eyes to be equally blurred. If they are not equally blurred, if one particular line is clearer, one particular eye is clearer, it means I have not given enough plus or I have given more minus than what is required. That is why I'm adding a little more plus to that eye. And when I've reached a point where both are equal, I go on reducing the plus gradually with both the eyes. Please move on. Okay, prism dissociation, like we said, sometimes this can be a little annoying for the patient. So yes, but it gives you very good results. Please go to the next slide. And the previous one. So over here, previous one, what you see over here is, it kind of looks like the duochrome itself put in two places, or when I saw this, I thought of using the duochrome in prism dissociation. Ideally, what you're seeing here is the dissociated single line where the upper one, which is clear, belongs to one eye and the lower one belongs to the other eye. So when they found that the upper one is clearer, that is made blurred by adding a 0.25 diopter to it. Okay, so that's a beautiful representation of it. So this just reminded me, you can use the duochrome also with prism dissociation to compare between the two. Try it sometime and you'll find that interesting. Okay, please move over to the next slide. Terwilly infinity balance. Believe me, I haven't seen this being done in the last, say, 28 years. There was a time in elite school where we used to do this for all patients, but now we have the easier alternate cover method which is being used. Try this sometime if you haven't done it really. It's nice to dissociate the two eyes, and with open eyes with a strip in the center, we can actually separate the two eyes viewing two different parts of that same chart. It's very interesting to note. So try this one time if you haven't done it. Please move on. So Polaroid filters, if it's the phoropter which is available, wonderful. Please move on to the next slide. Okay, so when would you not do binocular balancing? When we were talking about duochrome and all itself, when it was talking about binocular balancing, it was mentioned that if vision is not equal, you wouldn't do these tests. So that actually has to apply here. Binocular balancing is usually done only when vision is equal between the two. It is good between the two eyes, even if the power is different, right? The vision has to be good for us to appreciate that difference. Otherwise, binocular balancing cannot be done. And when there is strabismus and the other eye is being suppressed, obviously you cannot appreciate binocular balancing. Okay, so obviously, why do we do it? Because if I have a 0.25, suppose both eyes have +1 on them, one eye's actual power is plus 0.75 and I've put a +1. This other eye is going to relax a little more, or rather, let's take it as minus. One eye will be accommodating more. So when one eye accommodates, the other eye is also accommodating. Immediately a trigger comes, don't accommodate, relax. So this eye also starts relaxing. It's like a game it's playing. Accommodate, this eye accommodates. So it says stop accommodating, this relaxes, this also relaxes simultaneously. So it's going to be constantly in a factor of strain. So that is why it is very important to make sure that your accommodation is kept at a settled pace. Can we move to the next slide? Okay, now you know about the different factors which are going to affect your refraction, but please go by the fact of what the patient is doing, what kind of work they have. We are seeing plenty of people who work excessively at near, and like most of us who are listening to this also, we would be on our gadgets just before sleep for at least an hour, and then we strain our eye and then our accommodation is stuck. The patient comes in for a refraction. You have a -2. The patient is accommodating and the accommodation is like not relaxing. The muscle is still stuck there. Patient's not able to read with the retinoscopy value which you get, you'll have to push a little bit of minus because this is not coming to normal. Accommodation is not coming to normal. So this way, we are actually kind of pushing them into more and more of myopia instead of setting right their accommodation. So give a little care when you are doing your refraction to make sure that you're not just going by what the patient's eye is doing, and do them the justice that they've come to you for. Okay, so these factors she's already explained beautifully in these slides. Please go on. Inadequate cycloplegia. So that is a very, very, very important point, because when you do refraction, you are deciding for the patient that there is something wrong over there. So you're asking for cycloplegia. If it is not the correct cycloplegic agent instilled at the right time, and if you do not cross-check if the patient is properly cyclopleged, your result is not going to be as effective. So make sure you find out how you find out if the cycloplegia is adequate. You have a test for it. If you can go ahead and do it and then determine, okay, yes, this patient with that +3 is able to read even closer, accommodation is still existent. So you should not be doing the cycloplegic refraction at that stage. Okay, and observer bias, yes, we have something in our mind. We are not sure what distance we are working. All these factors come into play. So let's give some more importance over here. The major importance which is given is for retinoscopy. Well, in the hands of a good optometrist, that's the best device I can think of. Please move on to the next slide. It's the case. Okay. So over here, I'm sure you've gone through the case. You know what we're talking about. So 6/9 and N6 for a 25-year-old. N6 is there, so we're happy with that. Please move on. Again, we don't know what the patient is doing. Acceptance is plus 1.25 and again 6/6 N6. So with just 6/9, one line, I would think of only plus 0.25. That's why I said the rule of one line and 0.25 diopter applies mostly to the myopia. Please move on. So now my question here is, you know, can somebody just put up there what are all the things which are abnormal over here? NPC 26, is it normal? Obviously no, right? So if amplitude of accommodation is 3 diopters, okay, push up to blur, 3 diopters. So what is the NPA going to be? Anybody giving me a pop-up message for that? The method you do it would be, you're going to take the target close with the distance correction in place. You're taking
33.3, ma'am.
Lovely. So you're going to take the target closer. Yes, Harshini also 33.3. I don't know who gave the answer aloud, but thanks for answering. So as you take it closer, you stop at the point where 100% clarity is lost. 1 mm behind, it is 100% clear. Just a little closer, you can't accommodate to make it clear anymore. That is your NPA. Please do not push it till the patient says it's fully blurred, where 100% clarity is lost. So 33.3, is it normal for a 25-year-old?
No, ma'am.
Okay, so for a normal 25-year-old, it's got to be somewhere between 8, 10, 11 centimeters. If you go by the, what do you say, the minimum, average, and maximum, okay? So definitely this is bad, which is again telling us they might need a cycloplegic refraction. You can see there is an esotropia also in the fovea, which is again not a very good thing to find. You can see that the PRA is minus 1.25. The patient can hardly accommodate. So if their accommodation, this can either be accommodative insufficiency or it can be a cycloplegia which is required to find out if actually the patient is having accommodative insufficiency or if there is a hidden plus. Okay, ACA looks normal. The rest of it is fine. Vergence facility is good. And accommodative facility is slightly difficult and has difficulty clearing negative lenses, again meaning accommodation is your problem. This kind of people, you need to ask what their profession is and make sure you don't push more minus to them and give the maximum possible plus for their near correction. If they don't wear it for distance also, for their near task, you have to make sure that you give them the maximum possible plus or the minimum possible minus that is required. Please go to the next slide. Okay, so the slit lamp was all normal. And yeah, move over. Yeah, so a diagnosis was hyperopia and accommodative insufficiency. So before you make this diagnosis of accommodative insufficiency, it's important that you do your cycloplegic refraction and see what correction you can actually give them before you decide if it is accommodative insufficiency. And when you're mentioning it in a presentation, make sure you make it even more definite by saying that cycloplegia revealed this much and the patient did not accept anything beyond that. So that's also something which you should be remembering when you're seeing your patient. Okay, optical correction was given and the patient was given exercises again for accommodative facility. Generally, they would say that if your patient has accommodative insufficiency, how is the flipper going to help? So giving it a try is never going to hurt. Okay, so nice. The next one is the references. So thank you for that presentation. And if there are anything else which you want me to mention, because we are, I think, past the time.
We just have 2 questions from YouTube, ma'am. I'll
Sure.
read it for you.
Sure.
Why should we keep right hand for right eye and left hand for left eye in retinoscopy?
See, doing the retinoscope with which hand doesn't really matter, but doing it with the right eye for the right eye and left eye for the left eye makes sure that you're going to be on axis with the patient. It's like you use your right eye when you're refracting the patient's right eye, which means the left eye is given a chance to look behind you at the target too. So that is one of the reasons, because when you shift over to the other side, you have the right eye of the patient when you're refracting for the left eye to look behind. Reason why, when you have a squint, when you block the other eye, they don't have a region to fixate on. That's one of the reasons where you're going to be on axis when you're going to do right eye for right eye and left eye for left eye.
Thank you so much, ma'am. It was a very elaborative session. Even presenter as well as you giving an input for each and every particular slides means a lot, ma'am. Gomati, over to you.
Thank you, Meenakshi. Thank you so much, Renjini ma'am. That was an amazing explanation, ma'am. Thank you so much. Yes, I would like to thank Anshika ma'am also to roping in Renjini ma'am for the session. Thank you so much, Anshika ma'am.
Yeah,
So
thanks,
this will,
Anshi, for calling me over.
thank you so much, ma'am. We'd like to host you on another wonderful platform, ma'am. We'll have you here. Sure. Thank you so much, ma'am. Yes. Thank you, dear audiences, for your continuous support towards Optometry series. If you have any questions, please post your questions in the comment box. We'll get back to you with all the answers. If you like this video, give a thumbs up and share with your friends. We'll meet you in the next episode. Thank you so much. Thank you, ma'am.